Hello everyone, welcome back to CMME Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. In our previous video, we learned the different clinical features of dengue that included the classical dengue fever, the dengue hemorrhagic fever and the dengue shock syndrome. In today's video, that is a part 2 of the dengue series, we shall learn the different pathophysiological mechanism behind all these clinical features. The disease starts when a female Aedes mosquito bites a human and introduces the dengue virus in the host. So this is the virus, the dengue virus. We know there are 4 different serotypes: Den 1, Den 2, Den 3 and Den 4. So this is a dengue virus, and on its surface there are many molecules of glycoprotein. So this is GP1, glycoprotein 1 molecule. On the other hand, in the skin of the human we have a Langerhans cells, which is one of the different types of dendritic cells. One of the receptors present on the surface of the Langerhans cells is the mannose receptor. There is some interaction between the glycoprotein 1 of the virus as well as the mannose receptor of the Langerhans cells, and because of the interaction there is fusion of the virus to the Langerhans cells. This is how the attachment of the virus occurred to the Langerhans cell. After attachment, the virus is internalized. That means it is taken inside the cell or the Langerhans cell by producing endosome. This is followed by disassembling of the virus. That means the virus releases the viral single-stranded RNA. Also, it produces multiple viral particles. This is disassembled into multiple viral particles. This mother single-stranded RNA produces multiple single-stranded RNA with the help of RNA polymerase. So as you can see, initially from a virus we had one single-stranded RNA, and with the help of RNA polymerase it produces multiple single-stranded RNA. On the other hand, these viral particles that is released by the lysis of the virus, with the help of endoplasmic reticulum and Golgi complex, it produces even more number of viral particles. This newly produced viral particles along with this newly produced single-stranded RNAs produces multiple virus inside the Langerhans cells. So these are the progeny virus or the daughter viruses. This is how the multiplication of the dengue virus occur inside the Langerhans cells, and these Langerhans cells having so many dengue virus in it is known as the virus loaded Langerhans cells. Sometimes the Langerhans cells also have NS1 antigen inside the cell. So these white structures, these are the NS1 antigen as presented in this diagram. This virus loaded Langerhans cells reaches the nearest lymph node via any afferent lymphatics, and there it releases cytokines and interferons. These cytokines and interferons, they primarily activate the immunity, that can be innate immunity or humoral immunity. Also, these cytokines and interferons are responsible for the clinical features in classical dengue, like fever, there can be musculoskeletal pain, so myalgia, arthralgia can be there, flu-like symptom, etc. So that is how we get the clinical feature in classical dengue fever. Alright, now let us look at this. After this, this is the Langerhans cells having the viral particle and the NS1 antigen. They are released in the circulation, and we have now viremia because we have the virus inside the circulation and also we have antigenemia because we have so many NS1 antigen in the circulation. So this is viremia and antigenemia. Now whether we shall have a classical dengue fever or it will progress towards dengue hemorrhagic fever or dengue shock syndrome depend on a certain things. For example, if the person has strong immunity, that will lead to complete viral removal from the circulation and the person will have complete recovery. So that means there is febrile phase and after that the person is recovered and it does not progress towards the critical phase or the complications do not occur. So this is when we have only the classical dengue fever. But when the immunity is very weak, so the host immunity is weak, or if there is any comorbidity like hypertension, diabetes, or the person belong to any high risk population like it is a child or the female gender or the person is obese. Also, if there is any secondary infection with other serotype, that means the person was infected for the first time with a particular serotype, that can be DEN1, DEN3, DEN2 or DEN4, most commonly DEN1 and DEN3, and after few months the person is reinfected with a different serotype, that can be DEN2 or DEN4, whatever. So if all these things are present, then there is a possibility that the classical dengue fever from the febrile stage will proceed towards the complicated stage, that is the critical phase. So the further complications can occur and there can be occurrence of dengue hemorrhagic fever and dengue shock syndrome. Now let us look at this. This is the Langerhans cells with multiple viral particles, or virus, not viral particles, rather we should say virus. And there is a T cell present here. Sometimes these Langerhans cells attracts the T cell and there is interaction between the Langerhans cells and the T cell. This will produce the pro-inflammatory molecules like TNF alpha, interferon gamma, interleukin 6 and interleukin 8, and they produces different clinical features. Dengue virus can infect different lymphoid tissues, that can include liver. So if it affects the liver, because of the inflammation it can cause hepatomegaly. Also the liver enzymes may be elevated, so there can be elevation of ALT and AST, or we can say SGOT, SGPT, etc. When the dengue virus affects the bone marrow, there can be bone marrow suppression. Because of that we can have leukopenia, that means low WBC count, as well as thrombocytopenia, so platelet count may be low, as low as less than 1 lakh. And when it affects the spleen, there can be splenomegaly. So that is how when dengue virus affect different lymphoid tissue, we can have different clinical features like hepatomegaly, we can have jaundice, not necessarily jaundice, we can also have elevated hepatic enzymes, we can have leukopenia, that means lower WBC count, lower platelet count, and also splenomegaly. Alright. When dengue virus affect the bone marrow, there is thrombocytopenia. We have learned this from this particular slide. And thrombocytopenia means there is low platelet count as well as there is platelet dysfunction. So whatever number of platelet we have, those platelet may not act correctly or act properly. So it may not function the way it is supposed to function. And because of that, we can have different hemorrhagic manifestations. So this is how we can have the hemorrhagic manifestations in dengue hemorrhagic fever. That is because of the thrombocytopenia, which again occurs due to the involvement of bone marrow by the dengue virus. These hemorrhagic manifestations can be either cutaneous or even in the other part of the body. In the cutaneous hemorrhagic manifestation, we can have the maculopapular rash, or sometimes we can also have the white eyes in the sea of red. Now this terminology we discussed or explained in our previous video, but I shall once again discuss this in today's video as well. As you can see in this photo, the chest as well as the abdomen of this person appears red. Probably the arm and forearm are also the same appearance, but we cannot see. Now this red appearance these are the erythematous rashes, which is probably due to the subcutaneous hemorrhage. But there are also some places or some spots in the chest as well as abdomen, as you can see, which are pale in color. So here, this part, this, etc. That means these are the part where the hemorrhage did not occur. So that is why they appear lighter as compared to the skin surrounding it. This is what is called the white isles or white island in the sea of red. Remember, if we press against the skin, this will be non-blanchable. That means it will not be blanched. Also, there may be hemorrhagic manifestation in the other part of the body like epistaxis, which means the bleeding from the nose, gum bleeding or the gingival bleeding, also microscopic hematuria. But if the hemorrhage is severe, we can have hematemesis, which means the vomiting out of blood. Melena and hematochezia both mean the presence of blood in stool. In melena, we have the dark colored tarry stool, whereas in hematochezia, we have fresh blood in the stool. We can have vaginal bleeding, also dysmenorrhea can occur, and intracranial hemorrhage may take place. So all these hemorrhagic manifestations occur because of thrombocytopenia leading to low platelet count as well as platelet dysfunction, and again thrombocytopenia occurs because the dengue virus affects the bone marrow. So this is the pathophysiology behind the hemorrhagic manifestations in dengue, especially in dengue hemorrhagic fever. Previously, we have told multiple times that when a person has secondary infection with a different serotype, he is at risk to develop complications like dengue hemorrhagic fever, dengue shock syndrome, etc. There are multiple theories behind why this occurs. Many theories are quite controversial and do not have adequate evidence to support them. Today I am going to talk about a very popular and well accepted theory which kind of explain why this occurs. That means why the complication occurs after secondary infection with a different serotype. Suppose a person is infected for the very first time in his life with a particular serotype. In this example, let us say he is infected with Dengue virus. As a response to that, antibody will be produced in his body, obviously. This antibody that is produced after a primary infection has two characteristics. Number one, it provides lifelong immunity to the same serotype. So in this example, the person will have lifelong immunity against Dengue virus, which means if he is infected again with Dengue virus in future, he will be completely immune or completely protected against the disease. This antibody also provides some immunity or some protection against other serotypes like DEN2, DEN3, DEN4 in this example. And this immunity or protection is not lifelong, it is only for few months. Now let us say there is secondary infection in the same person, but this time he is infected with a different strain, say DEN2. Now the antibody which was produced during or rather after the primary infection, they will not be able to neutralize the DEN2 virus that was introduced during the secondary infection. Because of that, that means since this antibody cannot neutralize the DEN2 virus or any serotype that is introduced during the secondary infection, now there will be rapid multiplication of the virus in the host. This is known as antibody-dependent enhancement, because this neutralizing antibody from the primary infection, they attach themselves to the virus, the secondary infection serotype virus, and this complex actually enhances the intake of the virus inside the cell, and that causes rapid multiplication of the virus inside the host. So this is antibody-dependent enhancement, also known as ADE. And because of that, there is complement activation, formation of membrane complex, and inflammatory cytokine releases. So different cytokines like interferon gamma, interleukin 2, interleukin 6 and 8, tumor necrosis factor alpha, and also monocyte chemoattractant protein 1. So these are different cytokines. Their pro-inflammatory molecules. This is we already something we discussed in earlier slide. All right. So this is how secondary infection with a different serotype actually helps in rapid multiplication of the virus in the host, leading to release of inflammatory cytokines or different pro-inflammatory molecules, but in this case in much higher concentration or much higher amount. Now we shall learn why we have plasma leakage in dengue. This is the anatomy of blood vessel. Only a part of the blood vessel has been shown here. We know the innermost surface of the blood vessel, we have the endothelial cell layer. So these are the endothelial cells. In between them we have the gap junction. So there is a little bit of gap in between them. This pink color area is the blood flow or the blood, that means the circulation, blood circulation. This blood cannot leak out through this gap junction in between endothelial cells because of the presence of what is known as glycocalyx. Glycocalyx is generally made up of proteoglycans, glycoprotein, etc. Now we know in dengue infection there are production of lot of pro-inflammatory molecules. Especially in case of secondary infection, when we have a rapid multiplication of the virus, we have a lot of inflammatory cytokines, including interleukin 6, 8, TNF alpha, INF gamma, etc., etc. Right? So all these things. When we have lot of these inflammatory molecules gets attached to the glycocalyx through some receptors. This lead to the destruction of the glycocalyx layer by the pro-inflammatory molecules because of the inflammation that takes place in the glycocalyx layer. Now we have this gap junction open. That means right now the plasma or the blood can leak through these gap junctions into the extravascular area. This is known as increased capillary permeability. So let me repeat again, because of the pro-inflammatory molecule action on glycocalyx, there is destruction of the glycocalyx layer, and now we have increased capillary permeability because the plasma from the circulation can leak through this gap junction into the extravascular structures. So this is how plasma leakage occurs in dengue, especially during the critical phase. When we have plasma leakage, that means there is volume depletion in the circulation. Because of the volume depletion, we can have shock along with different features of circulatory failure. So we can have rapid and weak pulse because there is volume depletion, and rapid because the heart has to pump multiple times or in a higher rate to deliver blood. Along with that, the oxygen and the necessary nutrients to different organs. We can have narrow pulse pressure, hypotension for the given age, cold and clammy skin, and restlessness. So all these are features of circulatory failure that occurs due to shock. This is one of the clinical features because of plasma leakage. Also, since we have volume depletion, that means less amount of blood is reaching to different major organs in the body, leading to organ hypoperfusion, and then it leads to organ failures. So we can have acute kidney injury, acute liver failure, etc. Then we can also have fluid accumulation because of plasma leakage. So we can have ascites in the abdominal cavity, gallbladder edema, pleural effusion in the lungs, and also pedal edema, that is pitting in nature. And if the shock is profound and if it is not managed immediately, we can have death. So these are all the clinical features that occurs because of plasma leakage. Another thing that is very important and we must understand, we have different blood cells in the circulation. Especially we have lots of RBCs or red blood cells. The size of the red blood cells are much larger as compared to the leaks that we have here. So we have leaks through which the plasma comes out. So this is increased capillary permeability. All this gap that we have because of the disruption of the glycocalyx layer, the size of the RBC is much larger, and that is why only plasma leakage occurs through these gap junctions in between the endothelial cells. So what happens? There is decreased plasma level because of plasma leakage, but the RBCs cannot come out, and that is why there is relative increased concentration of RBCs, also known as hemoconcentration. That gives the picture of raised hematocrit. So that is how we get raised hematocrit in dengue, especially when the plasma leakage occurs. To summarize, today we have learned the different pathophysiological mechanism behind the clinical features in dengue. For example, why we have fever, musculoskeletal pain and flu-like symptoms in dengue fever, which is because of the release of cytokines and interference from the lymph nodes. Also, we learned why we have hemorrhagic manifestations and what are the different hemorrhagic manifestations. If you remember, this occurs due to the thrombocytopenia, and we learned why we have thrombocytopenia in dengue. Then we talked about the reason behind increased capillary permeability leading to plasma leakage and the different clinical features of plasma leakage, like shock, like organ hypoperfusion, and like the fluid accumulation in different part of the body, like ascites, pleural effusion, etc. Then we learned the reason of raised hematocrit level in dengue, especially during the critical phase, and also a very important topic was discussed, that is why following a secondary infection with a different serotype, a person can develop complications like dengue hemorrhagic fever and dengue shock syndrome. With this, we conclude today's session. If you like the video, please subscribe to our channel and share this video with your batchmates, juniors and friends. We also have our Facebook page. The link is given in the description, and you can also follow our Facebook page. Take care, and we shall see you in our next video.